excited to be able to come to you to have this conversation. Thank you, Kristen, for having us here and letting us just have some conversations that we've been having here in Georgia and that we continue to have on a regular basis around how are we going to address maternal mortality here in Georgia, and really grateful to be able to hear what other people are doing around this country around the same topic. We really want to have this experience to share some information with you, but really to have a dialogue about kind of what your perspectives are, what you're doing, so we can learn from each other, so we can advance this work. I think we can't practice or learn or make change in a vacuum. I think that we are all on this journey together with racial and ethnic disparities in our personal lives, our professional lives. I think that you cannot get by today without feeling it more than in your work. It seems to have permeated many of our spaces socially, in our institutions. So I really want to be able to hear kind of, what your perspective is. Think of this as sort of your time to release, right? To be with people that can relate and understand your perspectives without feeling shamed, without feeling judged. Just a platform to share and to get some insight into what you're doing. So our objectives today, we really want to discuss some of the factors that contribute to the racial and ethnic disparities that we're seeing today, specifically in maternal health. As you know, we have a national issue with Black maternal mortality. And so we're going to talk a little bit about that. And then we're going to learn some strategies for supporting and enhancing open and honest communication around race. We know that race is a very touchy subject. I'm here in the South from New York, so race is always very, it's a tough conversation, probably no matter where you are, but it's particularly difficult here in the South. And again, we're all talking about it, doing it, and what the main theme that we're getting is, yeah, we're talking about it, we're getting training in bias, and we're doing that. Now what? Now what do I do? What's next? So I thought we could have conversation today to kind of think about, like, what's next? Like, what do we do next? And identify maybe some tactics that we've kind of learned along the way, and some nuggets we picked up along the way from having these same conversations with other peers and partners and stakeholders in doing this work. Next slide. So as I said, Black moms are dying, right? The pregnant Black women are 3 to 4 times the die at the rate of white women around this country. I think you cannot miss a headline in really understanding that. And birth is really killing Black women. And they're dying really, particularly what we noticed here and again around the country from our conversations, our meetings, our other conferences and speakers, that it's really from these pregnancy-related causes that are really preventable. And Lauren will go a little bit more into that. And so that's really the disheartening, that we really have the ability to probably make some change and make change in trajectory in that fact. And it's really more than a health issue or sort of siloed in this space of maternity care. It's really a human rights crisis that we're faced with at the moment. Next slide. And so, you can't miss a headline to see that this epidemic, this human rights crisis affecting women from really all walks of life, right? It does not happen to the poor Black women on Medicaid living in like a small rural town. It's not happening to, just the woman who, only finished high school working at Walmart or, on public assistance, or the drug abuser. It's really happening to everywhere, women from every walk of life, right? College educated women. Shalon Irving worked on reproductive issues for the CDC, had a PhD. This was her work, and she lost her life. We have Serena Williams, who was, she's not a mortality, but she's a morbidity, right? Was faced with a crisis that really could have ended her life with a pulmonary embolism when she had her daughter. And Charles Johnson, his wife Kiera, who really bled to death in the hospital, who went into healthy, normal delivery, C-section. It was a second baby and lost her life as well. And a lot of what we're hearing resonating around all of these cases, these are stories from women from all walks of life. They really have not been heard. That has been the resounding sound of what we've heard, that they do not feel heard, they do not feel valued, they do not feel respected. And here in Georgia, we've done the focus groups and surveys and all of that, and really compared to the messaging around the country, and it's been about the same. And so that was the case in these experiences as well. These women reported the same issues. They felt like they not were heard, they were not valued. Next slide. And so again, this just speaks to it, you know, maternal mortality and morbidity is not really affecting one group, right? It's one socioeconomic category of women. So it doesn't even matter if you have a college degree, can you be saved? Come into, you know, the healthcare system well-educated, well-versed, knowing all of the things that you need to do, building your village, having all of the things that you have to take care of yourself that you've learned along the way. Not even a college education can save you with the current crisis that we're in. Next slide. So again, we said we are, it's a maternal health crisis. We have looked at some of the clinical factors that are an issue, you know, especially here in Georgia, but we also have to not ignore that there seems to be something more at play, because even with the advances that we've made in the clinical setting, and the work that is continuing to go on in the clinical setting and the gains that we're seeing, there's still something that we're not admitting or acknowledging. And that's really that maybe that there's something else we need to sort of look under the hood at, and maybe that thing is racism and overexposure to racism that may be the cause of some of what we're seeing. Why are birth outcomes for Black women so much worse? Well, you know, when we talk to our physician and nursing colleagues, there's a lot of blame going around, right? That they're sicker, that they're heavier, that they're more obese, they have higher rates of hypertension and diabetes, or they're more socially disadvantaged. And what we're seeing from the data, that is just not the case. It is not something that you can lay at the feet of Black women for the cause of the cause of maternal mortality, the cause of that they're dying at 3 to 4 times the rate. There are things that Black women can do, but we are not the cause of being sort of leading the statistics in Black maternal death. Next slide. And so you really cannot ignore the historical perspectives, right? If we're going to talk about racism, we cannot ignore the fact, the historical sort of landscape of Black women in this country. If we're going to look at race or racism, we have to begin to look at what has sort of impacted how we're perceived, how we're treated, why we're not listened to, why we're not valued. And you don't really have to look far to see that a lot of that comes from the historical perspective of in this country, right? Many people inaccurately believe that Blacks literally have thicker skin and experience less pain. You only have to look at the practices of Marion Sims, the father of gynecology, in his experimental treatment in perfecting a surgical procedure for vasovagal fistula and operating on his enslaved women, Annika, Lucy, and Betsy. And he performed these procedures for many years, 1845 to 1849, using suture to close and vasovaginal fistula, which is an opening between the bladder and the vagina, or the rectum and the vagina. He did those surgeries on women without anesthesia. He did them until he perfected them, and they really were not valued or even mentioned in any of the journal research that he did. We only have to look at Henrietta Lacks, who suffered with cervical cancer, and her cells were used against her knowledge. She had not even known, and her cells became really the cornerstone of a lot of what we see today in the research for polio vaccine and other really transformative medical procedures around cancer. She had a strain of HPV that contained multiple copies of this human papillomavirus. And she was just a poor woman with a middle school education. And although she lost her life, she really never was acknowledged for really her contribution to the science of this country and really revolutionize what we can do in research with polio, in vitro fertilization, gene mapping, and cloning. And that work was done by a German virologist who never acknowledged or really gave Henrietta Lacks or her family any acknowledgement. We only have to look at Black women who nursed, enslaved Black women who nursed white babies while their own children could not get the nourishment that they needed, that they were or taken away from them after they gave birth. We only have to look at the practices of Margaret Sanger in Planned Parenthood. And recently, I think this year, they talked about taking down her statue and her name off of Planned Parenthood because of her views on her. Yes, she talked about bringing contraception, for women to prevent pregnancy, but who was she doing that for? She sort of had the eugenics and sort of practice of doing it to sterilize the feeble-minded, the insane, or to really just to create an image of Black women who really were not deserving of their babies. And so the best way to protect society from them is to sterilize them. And so her use of contraception practices during her day in the 20s and 30s, and some of the literature and that you can read on that she published and the things that she had said, you really see that she was really not trying to help poor, minority, low-income women. She really was trying to really improve the human race through eliminating sort of a race that she felt was inferior. And so those practices and that history is with many Black women, and you cannot ignore those perspectives. And the impact that they have today on how women seek care, their trust of the medical system, their belief that the medical system is fair and just for them. Next slide.
Sorry, Kaprice, I'm just going to change the slide view because they couldn't see it. Sorry about that. Sorry, everyone.
That's okay. Next slide. And again, there all of those things that we see with that happened in that historical perspective, this has caused a lot of historical trauma to Black women. That historical trauma over time has led to the high rates of infant and maternal mortality that we see today. Those historical traumas live and breed in the women that birth babies today, not only in the women, but also in the babies. And the impact that those things have had cannot be ignored. People say, "Oh, it was so long ago. What effect can it have? What effect can it have?" I know that my mother-in-law is in her 70s, and I'll be 50. That we still hold on to a lot of that distrust and lack of seeking out the healthcare system for all of our needs, because we just do not trust that they value us and will take the best care of us all the time. So it can be very scary for us in the healthcare system and impact how we're cared for, how we seek care, and ultimately our outcomes. And this book, Medical Apartheid, goes into a lot of that historical perspective. It's an excellent read of the historical perspectives of how the medical practices of physicians and training and physicians around this country from really slavery times till today have used Black bodies for their value to advance their careers and not doing what's best for them. Next slide. That historical trauma lives and breathes inside the bodies of Black women. And how is it manifested? It's manifested in a host of physical challenges that the body faces. Is it the reason that we see preterm birth rates higher for Black women than for white women and Hispanic women? Is it the reason we see higher rates of preeclampsia and inflammatory disease and obesity and neurological dysregulation? Is it the reason that these chronic conditions are manifesting themselves in the bodies of Black women? We cannot discount the historical traumas, the historical impact that it has had on these women. And we have to take a step back and begin to acknowledge that there is something more going on that we have to look at that could be impacting these chronic health conditions showing up in Black women. And it's not their diet, it's not all of the external factors, that maybe there's some intrinsic factors, societal, that's beyond the health system. Next slide. Next slide. And so again, this trauma, this historical trauma, the traumas that women face today that are not historical, that are day-to-day, impact, cause a sort of weathering on the Black woman's body. Those chronic health conditions, those exposures to even everyday traumas of dealing with race, dealing with economic challenges, dealing with familial challenges, dealing with the system, institutional systems that you have to deal with all the time in your experiences, growing up as a child in your neighborhoods that you grow up in, the schools that you attend, how your educational attainment, all of that can have a wear and tear on the body. Arlene Geronimus calls it a weathering, or really it can be thought of as an allostatic load on the body, right? It's a cost of chronic exposure to elevations or fluctuations in the endocrine or neural responses resulting from chronic and repeated challenges that the individual experiences as stress. So it's really constant, consistent stress on the body. You always, I know as a Black woman, you feel like you have to work twice as hard to get the same, attain the same achievements as sometimes your white counterparts. You have to, go to school twice as long. You have to get twice as many degrees. You have to speak up twice as loud. You have to work twice as hard to get into better neighborhoods, into better schools. Those realities today are today. Sometimes you are the breadwinner in your families. You are the matriarch in your families. You are the one taking care of your family because you are the one that has been the most successful. That wear and tear on the body can lead to the chronic weathering that we see and manifest itself in some of these chronic health conditions that we see. So yes, there's historical trauma, but there is trauma that we live and breathe every day. Our exposure to trying to be sure that we are seen and heard in our work settings, are seen and heard in our children's schools and in society, to look at us in a way that we feel valued and really equal. So that has an effect on what we are seeing manifested in our maternal and infant mortality. Those numbers cannot be ignored in the effect that it has. Next slide. And health is more than healthcare. So we talk about, yes, we can have women eat right and exercise and, take your medication, don't be late for your appointments. But really the challenges that we're seeing in the chronic health conditions and maternal mortality, what the literature is telling us, that those effects are beyond healthcare. It is, according to the CDC, it's really has a lot and other research is that it's really these social determinants of health that are impacting our health overall beyond what the healthcare system is. It's the economic and social conditions that influence the health of people and communities, and they're shaped by the amount of money, the amount of power and resources that one has. The CDC itemizes that these factors is early childhood education, like I discussed, employment, the type of work that you do. Are you a frontline worker? Are you a Fortune 500 CEO? Your housing, your income, discrimination, your social support, and any absence of those factors can negatively impact your health. If you're working 2 and 3 jobs so you can live in a better neighborhood, that is overall impacting your health. The wealth income gap in this country, I think no one has to really tell anyone here, that is growing, and Black people are not, the gap between Black and white is getting even wider. So the environments and systems that we all interact with are having probably a more substantial impact on our health than me coming in and missing my appointment in just my healthcare. It's beyond healthcare. Healthcare is, we can fix some of the things in healthcare, but we have to remember that those social determinants, those societal factors, we cannot ignore making those a part of any plan that we think we're going to do to make a change for Black birthing women or Black people in general. Next slide. So this is just another illustration of that, of all the stressors and societal, socioeconomic, physical environment that we all have to deal with. The justice system, poverty, poor schools, limited redlining. I know many of you have heard of all of those factors that are going on today. I was reading today that Mnuchin, that works in the Trump Trump presidency, he lifted the ability for the Fair Housing and Lending Agency to be policed, or really loosen the guidance around them so that their lending practices will not be scrutinized at the same rate. That same agency is responsible for setting the laws, setting the guidelines for lending practices for banking around this country. And we all know that Black people have been left out of borrowing money, not being able to borrow at the same rate. They have been discriminated against and disenfranchised by that system. We know that buying a house is the way that you build wealth. If I'm not able to be included in that ability to attain wealth, then again, that gap between Black and white will never get smaller. We will continue to see the Black and white wealth gap just grow and grow and grow. Next slide. And so again, we said it's systemic, right? It's intergenerational trauma. So again, we can't look at only the personal solutions to this. We're going to really have to look at the systemic solutions to fix this problem. Next slide. And this just illustrates that we talked about that we believe that it's overexposure to race, because there is a system advantage based on race in this country. I know people aren't comfortable talking about it, but it's a reality and it's a fact. You can ask any Black person, any Black that you know, what their experience has been. I know mine has, I've been fortunate and done well, but I also know that I've had some experiences where at different levels where I have felt that the system, I felt disadvantaged by the system. I grew up in the projects. I did not grow up with a silver spoon. My mom didn't work. I was on welfare. I was able to, go to college, and I did have some advantage, but I did, and I continue to have to work, I feel, twice as hard to really get to the same level as my peers, as far as income, as far as housing, as far as, what I can attain in my professional life, that all of those things are there. So these structural, micro and macro level systems that are in place with embedded policies and standards and laws and just impermeated into these institutions are there, and we have to dismantle them if we're going to see any change. Lauren?
So a lack, as Kaprice has told you, a lack of health equity leads to health disparities, and that's influenced by several different factors, as you can see on the screen, whether it be educational, income, racism, or environmental. So we don't want this to just be a session where we talk at you. We want this to be interactive. So we would really like for you to take a poll. We haven't set up a poll. So the easiest way to do this is probably for you to type in the chat box. So the question is, do you believe that exposure to racism can impact the health of Black women? If you believe yes, can you type yes? And if you think no, no. And if you're not sure or you don't know, you can put don't know. Let's just keep it to those three. And I will ask Kaprice if you would.
Yes, I'm looking at the chat. Yes, I'm manning the chat. I'm manning the chat.
Thank you.
We have a progressive audience because most people are saying yes.
Good.
We got to bring in the no people. We have to bring in the no people.
And if you believe no, that's it's a place to start having a conversation, and that's what we want to do today. Has everybody had the opportunity that wants to vote to vote?
Quite a few yeses, Lauren.
Okay.
And it's hard to get the no people to show up, I know.
So what our goal is today, well, we'll start with what our goal is not. So it's not our goal to make you feel bad, to shame you, to blame you, or to attack you. This is really an important conversation, and the mere fact that you signed up to attend the session clearly tells us that you are interested, you want to know more, you're on that journey to work towards reducing racial disparities in health and in the populations that you serve, and also that you may have something to contribute, and this is an opportunity to learn. However, because it is such a deep topic, some may feel triggered after this session, and we don't want to make anybody feel uncomfortable. We, as Kaprice said earlier, want this to be a space where we can have these open conversations, and it's not just going to be today in this hour, it's going to continue long beyond this. So we do know that it's difficult and it is a little bit uncomfortable. It's uncomfortable for us all, but without addressing the issues, we won't be able to move forward. So our goal today is to get you to think, and to think critically, to disrupt current thought processes. And this goes for everybody, for all of us, even for Kaprice and I as Black women, and for other BIPOC women. There are things that maybe we haven't experienced, so we may not have experienced some of the most extreme cases. Both Kaprice and I are mothers, and thankfully our situation hasn't been like any of the ladies that they mentioned earlier. She mentioned earlier on. We're also in the healthcare field, and we see extremes of circumstances. So even us being on this journey is helping us to think and think critically, and disrupting our current thought processes, so we can move to a new space, to have these conversations, to be in these spaces where we can start just really attacking some of these issues. Sometimes we can feel quite helpless, like this is a mountain, it's too big, but every little change every little step is a change. And we want really to disrupt the thought processes, the current thought processes that we have, that you all have about ourselves, our families, young people, people that we know, Black people, and our communities and society as a whole. So I want to be able to bring into context what we're going to talk about today, and share a little bit of what we did in Georgia with regards to Black maternal mortality. So as you can see, I'm going to start a little bit globally and nationally. This is the states. This graphic was taken from the CDC from 2019 data, and all of the states are colored in blue. The darker the blue, the higher the rate of maternal mortality. We are from Georgia, so you can see we have one of the highest rates, and of course there are other states that have high rates, and then you can see the ones that are in the light blue that are doing fairly well, and those that are somewhere in between. And why aren't all the states like these states that are in light blue? That's the question. Or should it be, why are these states in darker blue?
Yeah, what's going on the west side of that country?
Yeah, absolutely. So I wanted to share this. This came from the American Journal of Obstetrics and Gynecology earlier this year. And what they've done, if you recall the slide that we had previously, which was all of the states and their maternal mortality, what this slide depicts is where these states fare in comparison to global countries globally, the maternal mortality rate. And I wanted to give you a moment just to look at this slide and to really just scan and see where your state is and where it fares in terms of maternal mortality with another country. We're in Georgia, so our country's maternal mortality rate is equivalent to the rate in Syria. And here, this is Mississippi. Is it Mississippi? Yeah.
I think Louisiana.
Louisiana, I'm sorry, thank you. My geography, American geography is not very good. So you can see that that is pretty bad as well. And the reason why I wanted to bring this, and you may already know this, so again, forgive me if I'm speaking to the choir, but we often reference, we don't call them third world countries, but we might call them low and middle income countries, how some of them are doing so much better than states in the US, which is considered a high income country, industrialized, have good access to healthcare. But why are we faring like this nationally? Why are we faring like this globally? It really does beg food for thought. Why such a, what we would consider a rich country where a lot of us come for better opportunities, for the American dream. But for some people, that dream turns into a nightmare. And then I wanted to just bring it into context and compare how Georgia fares in the United States. If you look at the graph to the left of your screen, this is the maternal mortality in the United States. And you've got Georgia on the far left column, and then the US. So you can see Black women in Georgia die at a higher rate than in the rest of the US. And on the right, this is also very interesting. This is for white women. White women die at a higher rate in Georgia than they do in the rest of the United States. So we acknowledge that this is not just a, while it is an issue for all women, even though we're talking in the context of Black women today, we do have a problem in Georgia with women dying. And in 2019, when this was reported, it's still too much. So we do have one of the highest maternal mortality rates in Georgia. Our maternal mortality ratio for 2017 was 46.2 per 100,000 live births, per 100,000 births, I'm sorry. And this statistic came from the CDC. So as many other states, and I think there are very few states that don't have maternal mortality review committees now, Georgia has had one since 2012 and has been reviewing, since 2014 and has been reviewing the deaths of women since 2012. We're currently reviewing deaths for 2016. We were really kind of far behind the deaths simply because there was only one person doing abstraction. There wasn't the infrastructure there wasn't the sufficient funding. That has changed in the last year, and there are now more staff that are dedicated to full-time to doing abstraction. And one of the goals that we have is to be within 1 year of reviewing deaths within 1 year of the current date. So we are working on that. We are working to get caught up and review these deaths. We didn't want to skip any of the years. So we've got data now from 2012 to 2016. I think we're awaiting that report. So what I'm going to be showing you with regards to Georgia is aggregated data between the years of 2012 and 2015. So this is our most recent report. And again, like I said, that was produced in 2000. It was the report for 2000. Actually, this is incorrect. I think it was produced, this came out in 2019, forgive the typo. But there's several things that you can see on this graphic. The number of deaths, total maternal deaths in that time period was 67. Some of those are pregnancy associated and some of them are pregnancy related. And of course, pregnancy, once you kind of go through the data and you try to identify a cause, we're focusing mostly on the pregnancy related deaths because we want to know, is there something that could have been done during pregnancy or within 1 year of delivery that could have made a change to this? 2/3, 60% of those deaths are preventable. Black women are 2 to 3 times more likely to die than white women. And I want you to look, I'm sorry, I don't have a really big pointer here, but I want you to kind of also focus in on this little graphic here where my pointer is. And the 66 is the number of women who died that were on a Medicaid insurance, and those that were non-Medicaid insurance were half as likely to die. Or so should I put it the other way, women that were on Medicaid were twice as likely to die as those that were not. And we know a lot of that is directly related to this graphic, which you can't see very well in this slide, I'm sorry, but we will share these slides so you will be able to see this. But this graphic in the middle here is actually showing the rate of maternal mortality in relation to the timing of death. And the majority of deaths in Georgia took place outside of the hospital environment, and was between 6 weeks and a year of death. So that's the highest cause. And what happens then? That's when a lot of women here in Georgia, particularly those that were on Medicaid, no longer received any insurance, medical health coverage. So of course they didn't go and get the help that they needed, because they were marginalized by that aspect and not able to either pay for health insurance or have access to. And I will just say there is actually some great steps that are happening right now to really look at this. I'll mention very briefly about the pregnancy-associated deaths. Georgia did convene a what they call a task force to start looking at the pregnancy-associated deaths, and that's kind of gone a little bit quiet because a lot of the focus went to this pandemic called COVID, and of course we haven't been able to focus on that, but that is something that's going to be addressed. In addition, there are some new initiatives that are happening nationally that are focusing attentions on preventing maternal or decreasing maternal mortality in outpatient settings once women are discharged from hospital. I'll hand it back over to you, Kaprice. I'll just mention quickly that the Georgia Perinatal Quality Collaborative did convene a health equity committee. Like many of the states that you are working in, we started with hemorrhage and hypertension bundles. We first started with hemorrhage, and one of the recommendations that we were to infuse equity into the patient safety bundles. Really, we heard the call from the collaborative, from the clinicians. Well, how do we do that? So in order to assist with that, the Georgia Perinatal Quality Collaborative convened a health equity subcommittee, and Kaprice was the chair of that, and she was able to mobilize and connect partners to really start digging deep and addressing, trying to look at what the issues were and how they could provide guidance and equip the PQC and the facilities with tools and recommendations and strategies for how to infuse equity into the safety bundles. Did you want to add anything to that, Kaprice?
One thing, if it's okay, there was one question that was specific to a slide, so I wonder about kind of answering that question.
I'm sorry, let me
go. Aisha was asking, I'm not sure if you want to clarify.
Aisha, can you unmute and ask? Because I have to go back.
Where you were showing Georgia's Black maternal mortality against the US. Was that the US in general, or was that the other Black mothers in the US? I was just asking if the comparison was Black to Black or Black to all.
Oh, yeah.
Which, if you could let me know which slide, we can certainly go back if that's okay, Kristen.
Your blue slide of the map, the national map.
No, it was this one. Yeah, this one.
Oh.
So tell me.
So was this a comparison of Georgia Black mothers compared to all of US, or compared to US Black mothers? That's what I was asking.
Compared to US Black mothers.
Okay, thank you.
No, excuse me, I'm sorry. All of the US, all mothers. And the one on the right is white women to all of the US. Of course, it's a lower rate, but you can still see that the rate of white women dying in the US is significantly higher in Georgia.
Yeah, if you look at the
Georgia needs help.
Yes.
Georgia, it's not funny. Georgia needs help.
I always tell people, I'm from New York, and I'm in the South since 2004. I'm like, it's the South. What do you think? I mean, just look at all the South. Look at all the South states. Just look at the numbers in the South.
I have so many of our Amani affiliates that are in Georgia, so this just breaks my heart to see this.
Yeah, and you know, contributing to that is that we've got huge areas of healthcare deserts. I think just this year, between last year and this year, two more labor and delivery units closed their, 2 more hospitals closed their labor and delivery units, and we've got places in the state where women have to drive 3 hours to get to a labor and delivery unit. So a lot of them end up delivering in emergency rooms, or using their
primary care docs,
or other healthcare providers to deliver their babies. Yeah, it's a real problem.
We have more than half of our births are Medicaid. We do not have really the advanced role nurses. I know that's not, people don't like that, but our nurse practitioners, our midwives cannot practice here without sort of the supervision of a physician. And so physicians also can't keep their doors open and make a living in rural counties where more than half of the income coming in from, obstetric care is Medicaid. Having a baby, obstetric care at a hospital can be not a money maker, but can really be, you could lose a lot of money. So a lot of the smaller rural hospitals with a lot of change in ACA, with a lot of change in sort of federal funding, really got impacted by their ability to serve poor communities. Their funding really got impacted, and they can't make a living in these communities. So they go to cities where it's more robust, it's bigger population, and so those areas don't have the care that they need. So it's a real challenge.
And just another, we could talk about this forever, but we know we've got a time constraint. But there are none of our rural counties have maternal fetal medicine specialists. So sometimes women have to drive or be transported over an hour, 2 hours to see a maternal fetal specialist. We do have telehealth that helps with that, but one of the things that Kaprice talked about earlier on was redlining, and there's a new phenomenon called digital redlining, which means there isn't either the infrastructure, there either isn't the internet bandwidth to extend to some of the rural areas. So telehealth is not an option. So it's and this is 2020, and this is happening. So.
Yeah, I would love to hear if people that are from rural communities, what you all are doing. They're not very progressive here. The medical MAG, it's called MAG, the Medical Association of Georgia. They have a strong hold on holding power here, and so that can be a challenge as well. We also have a culture of a health department that doesn't function and serve the communities for maternity care, for prenatal care, so that they're there, but they're not offering services to women for just prenatal services. So they're not creating a safety net in their own community. We have over 159 health departments. We should have prenatal care in every health department here. So it's just a lot of weird sort of bureaucracy, policy structures here that are really can make it very difficult for women in our rural communities to get access to care. I mean, when we talk about access, we're really talking about access.
And I love what I'm seeing in the chat. Aisha, you said Medicaid makes it hard for midwives to accept their coverage. In Georgia, yes. And we know in some states that there are midwives, whether it be certified midwives or certified professional midwives, that can see patients and are reimbursed for that. And thank you, Linda. Yep, APHA has identified broadband access as a social determinant of health.
With COVID, there's some silver linings in COVID. We'll take it.
Binta, you said that the problem is coming from state health insurance. Can I just clarify with you? Are you talking about like
Medicaid?
Medicaid? Yes, yeah. All right, I'm going to hand over to you, Kaprice, and you can talk about your plan.
Yeah, please. We could be on the soapbox about access issues all day. And Lauren, you talked about this, that in Georgia, we do have some good things. I mean, it's not all bad. We do have a maternal mortality review committee that's been reviewing the deaths of women since 2012. We do have a Quality Collaborative. We do Quality Collaborative that's looking at the top causes of maternal death from pregnancy-related causes. So our hemorrhage, cardiomyopathy, hypertension, preeclampsia are our top 4. They are, they've adapted these sort of roadmaps to process and structure measures to begin to standardize care across our birthing hospitals. Over 86% of our birthing hospitals engaged in this QI work. So everyone is, most all of our birthing hospitals are on board to improve their standards and policies around these leading causes. We've had some really great outcomes and move the needle with hemorrhage and standardizing, put in the drape bag, quantifying QBL, you know, all of those things that seem small have really made a difference and an impact. Debriefing after a hemorrhage, those kinds of things. We've really seen some real wins in that regard, and we're currently working on hypertension. So this, you know, we also instituted this health equity committee because they realized that we really need to focus in on race. So that was a win. We were really happy. They were not talking about that as much as the maternal mortality review committee. So we're really super, super excited to see it in this, in our quality collaborative. So Georgia has some great things, lots of great partners working together. Everyone is hyper focused on it. So we'll turn the tide on what we're doing here. So we're super excited about that. They also have really integrated the racial disparities bundled into their overall work. And really one of the key recommendations that came from that racial and peripartum disparities bundle is looking at implicit bias. It's sort of the low-hanging fruit. I'm sure everybody's doing it. If you all are not doing it, you'll probably be hearing about it soon. And so next slide, Lauren. Implicit bias was really one that we cannot ignore. We know our biases can in fact impact you know, the health care that we give. We all come with them, right? It's ingrained in us. There is no way around it. They are not conscious, they are unconscious thoughts. They do impact how you treat, how you see, how you, you know, how you practice as a practitioner. These biases and stereotypes, they do come up. And if you think that you don't have them, then you're probably not very self-aware. But something triggers them. So it's not that you go in trying to be, biased toward people. They can be triggered by unconscious behavior from your own personal history, your community, how you're socialized within your own spaces. These biases affect decision-making and can have negative effects. They affect the patient's safety all the time. And so as we are learning and going through trainings, we just did a great training with Speak Up with the perinatal, what's the name of the?
Perinatal Quality.
Institute of Perinatal Quality with Deborah Bingham and Renee Byfield, which was super. And again, we need to elevate that as at least a baseline strategy to provide education, because we know that bias affects our attitudes, our behaviors. If we pay attention, if someone, is coming crying in pain. I know when we have an Indian patient, the doctors will say, oh, she's never going to deliver. She's not going to push well. Or we have Hispanic patients say, oh, they always yell, they always cry. You hear it from the nurses when you come onto the floor. You hear it from your colleagues when you're giving report. It's there, it seeps out. You roll your eyes in some of the things that you say, and you joke about them, but just think about those things can impact the care that maybe not that you give, but that your colleagues give. And what we learned is that you have to speak up and call out these things, right? Don't just categorize or stereotype people, and your perceptions can be affecting the care that they're receiving. They feel it because they are speaking up and saying they don't feel heard, they don't feel valued, they don't feel listened to. Next slide. All right.
So we're going to do another poll. And this is really to bring into context the talking about bias and implicit bias and whether, ask yourself, have you ever been treated unfairly because of any of the following? And please use the chat to just respond to that. I think when we asked this question before, we did have some people that said they don't know or know. And so we thought for those that have never been treated unfairly because of anything.
And not from race, right? It could be from
right, anything. Right. I had someone tell me that they were unfairly treated because they were blonde. So, and you know, we might laugh about that, but you know, there are jokes associated with being blonde, isn't it? So, and for some people, they take that very as an offense.
I just think about how people who are overweight are treated. I know if you see them eating when you're out, I mean, just think about how your biases can show up. I know when mine show up, I know that they're there and I recognize them. But I think that a lot of this that we're doing in our spaces of work have really helped highlight when they're showing up. So next slide. And you know, I love this quote by Maya Angelou, because when you know better, you do better, right? My Nana used to say that too. And you know, when you educate yourself and you know that you have those biases, you have to check them at the door. You know, bias is malleable, right? You can change, you can grow, you can be transformed by having a knowledge of what you're doing. Just think about when you're dieting, it takes a lot of concentration and focus. And if you're overstressed it takes like zero in and focusing on sort of what things trigger you, zeroing and focusing in on sort of introspectively on your behaviors. It's the same thing I think about with bias. And so we also cannot ignore naming the elephant in the room, and that race is one thing that we don't really like to talk about, especially in our professional settings. It's sort of taboo to talk about it, but we have to have those important conversations. So yes, we can call it up, you know, by another name. And, you know, with the mandates that came down from the White House about talking about racism and in professional spaces and mandating the language be changed around diversity and inclusion is only the tip of the iceberg. If you really think about what that means to the people that have really been trying to use this opportunity that's going on the national front about Black Lives Matter and what's going on as it relates to all of the inequities we are seeing in other areas. We have the door open, and we sort of have the ear of the country that we also want to begin to have these really challenging, important conversations. And we don't want to have them shut down. We have to keep the focus on racism. So policies and mandates that come down to say, no, we can't talk about it. No, we can't use certain words. No, we need to close the door. It only stifles the progress that we really need to make. You know, the civil rights movement was in the 60s. We are in a new civil rights movement today. We are really trying, and if we're going to move the needle, we are going to have to say the words that make people uncomfortable. And, you know, and it's not about trying to, again, Lauren said, we're not trying to hurt feelings. We're not trying to trigger people. We're just trying to have a dialogue so that people on both sides feel valued and feel validated. And addressing it, you know, in our work is a root cause of if we're going to advance public health, we have to look at the systems that are impacted, the policies, the laws and practices. Look at some of the practices in your own facilities. Look where you work. Look you know, when you go to do things, why certain laws and policies are in place. A lot of the public health interventions we see here are really trying to get at the sort of fix the problem, but really do not really get at some of the root causes. Like, for example, you know, you want to provide transportation for mothers on Medicaid, but then they can't bring their kids. No, they only can have themselves on the van if they have an appointment. They can't bring their children on the Medicaid van to get to an appointment. They can't bring their they can't have anyone else ride the van. Well, if I have a 4-year-old and a 3-year-old, and I have a medical appointment, how am I going to get there if I can't afford childcare? If I can't leave my children with anyone? They're not in daycare. How am I supposed to be able to make my appointment? So when you think about some of the policies that are in place that you just have to shake your head and say, this just doesn't seem right. Like, who was thinking? It kind of makes it worse. And so downstream interventions are more likely to perpetuate inequities. So again, when you think about, you know, the interventions that you're doing, you want to look at, is this going to cause more problems than good, right? Is this going to, you know, with all of the overdiagnosis of children with ADD and ADHD.
So can you also hear me? I think Kaprice is frozen a little bit.
I'm sorry. Can you hear me?
I'm sorry, I think it just froze a little bit. I think it was my internet. So we'll move on to another poll question to get your feedback on this. think about the environment where you work, and think about everything that we've kind of talked about today and in this conversation that we're having together. And from what you know and what you've experienced, in order for change to take effect, what in looking at and addressing racial disparities in healthcare and bias, what do you believe would have the biggest impact on changing behaviors and norms? Do you believe it's a change in policies? So if we enforce policies in our work environments that and tell everybody to treat our patients respectfully and not to have any bias and to not use any racial or disparaging language or behaviors? Or do you think it starts with a change in mindset? Do you think it's an individual thing that we have to change our mindset first before we can really start to make changes? I don't know what you're seeing in the chat, Kaprice. Are we getting some good responses?
Change in mindset, they're intertwined, but people need incentives. I believe we've been talking about that. You know, Lauren and I go back and forth. I'm like, when you think about what's been done, if for nursing, I'm like, well, would we had to stop induction before 39 weeks? It had to be a policy change. It had to be legislated so the doctors, you know, they wouldn't get paid. I mean, it had to be a big policy change. Does anyone have an example when they think of, you know, it was just a culture of change of mindset where something really worked or got affected or impacted where you work or anywhere in your community? The biggest change came from a change in mindset, or does mindset come before, or does mindset come after the policy change?
Yeah, we have these conversations because also we know that sometimes, you know, we can have policies in place that, you know, like you must do this, you have to follow this, this is the law. And we can go through that route, but, you know, in our minds, you know, if we're not bought in as an individual, and again, you know, I'm not saying one is right or one is wrong, but it's a question to start. Did someone have a response? Did someone want to come off mute and just share something?
Aisha said, let me see, Aisha had a good comment. Aisha, can you say what you're
going to say? The 39-week induction thing is not precisely an analogous example because that is a concrete, that's a specific stick a needle in their arm and start an IV procedure that you can dictate. That is not that same doctor still being able to tell a racist joke on morning rounds out of earshot of the policymakers, as once happened to me, and then follow it with, my goodness, I'm glad that little colored girl isn't here this morning. She might have been.
Oh my goodness.
Yep, morning rounds in a hospital.
Yeah.
On a medicine service. I was like, wait a minute, I'm offended.
But again, so what do you think would be like a change in, and I was thinking of when have I seen like something to be done that really made a difference and impacted a large group of people? That's why I thought of an induction, but in a change in mindset. Lauren used to be a nurse manager. She had some things in how she got sort of the nurses and the doctors to make a change sort of in mindset. I think it's a little bit harder when we're talking about you know, changing policies around race and how you treat people and your biases. I think it's hard. Yeah, we can say annual training, and we all do. And if you have, if you're any medical system or even education, there's annual trainings and things you have to fulfill every year for relicensure, for credentialing. But when you think about changing your mindset or how you feel or how you think, what has really done that? Something probably done consistently and persistently. Pregnancy dramatically decreased HIV exposure to infants. However, we are hearing that this is backsliding because it relies on continuous education and reminders. I think, you know, with all of this, we can't take our foot off the gas. And so, you know, messaging coming down from the White House to say, you can't say this, you can't do that. Institutions really limiting or restricting what you can talk about, or not really allowing for a culture of open dialogue and change can be stifling and keep keep this in the shadows and keep change from happening.
I like what you said earlier about the two are intertwined. I agree. I think to some extent you can't necessarily have one without the other. You do need policy to guide your direction, but you also need to be bought in. And these are some of the things that we are talking about in consideration when we are addressing racial bias and implicit and complicit bias in work environments. Just as the example that I think it was Janet that shared, why did that physician feel okay to say that, and who was, do we always feel strong enough to call someone out, and what's the backlash from that? So it's easy sometimes to say we can have a policy there that protects us, but then we know that sometimes that doesn't always work, and so it does provide guidance. It does provide a best practice and a benchmark, but also it can become monotonous, and we've got to change our mindset, because that is what is going to really kind of help to raise and change and increase awareness.
Yeah, I like Kristen said the C-section rate dropped quickly in Washington when Medicaid started paying for the same for NSVD and C-section. I'm telling you, I'm biased. That I'm telling you, if you're dealing with medical people, they need the policies to really, you'll see it the fastest when you do that. Even doing, changing simple things, standardizing things has really kind of given the biggest impact. In the community, maybe not as much. There is a mindset that comes with humanizing of the person, people that receive it at the receiving end is where I see change in practice happen. Yeah, I think in bringing their voices and making them a part of anything that you're doing. We're always talking about women here with lived experiences, right? They need to be a part of the conversation. I can't do anything to help you, and I don't know how best to help you or what your needs are. I think that leaving them out is not the way anymore. I think speaking to women and asking them what they need, and that can be, anecdotally, one woman at a time, speaking to a group of them, just asking them, what do you need? What works for you? What are your struggles? I think making them a part of the conversation is what we're seeing a lot of in our work, is that bringing women into as making them a part of these decisions and interventions and a part of the conversation, what's working, what's not, where do we need to make improvements, and having their voice really be heartfelt, right? Let's hit them in the heart and maybe we'll change their mindset if they can feel it. Maybe that will be the change that we need to see. If you can feel what your actions are doing, if you can see the impact that it's having by hearing the voice, the feedback of the person on the receiving end, maybe that will be the difference. I think that we have to begin to really think a little bit more inclusive about how we are going to try and make a difference in moving the needle on maternal mortality. So what actions are you willing to take based on the things that we said? Like, what can you do immediately? When we talked about, policy change and mindset change, and it starts with you, right? We have this Washington, D.C., I'm on a project, and they had this whole thing about how do they get the doctors to kind of pay attention. They had this do no harm checklist, right? Check your, and sort of getting them to check in with their biases. Like, how are we going to get them to be different, to know better and do better, right? So they're going to do check your do no harm. Let's sort of change it a little bit. Look at the data within your systems, right? Check your systems and your individuals. Check the entire care team from the front desk to the physicians. Is everybody treating everyone respectably? Check your biases, of course. We talked about that. Check each other, right? So you hear, like you heard the doctor saying those things. Are you speaking up to say anything to him? Are you calling him out? Are you pulling him to the side? Are you ever mentioning him that that's not okay? People are listening. People can hear and might be affected by that people might be offended. I think that if we don't call it out and let people get away with that type of behavior, then we're doing a disservice to women, to ourselves, to progressing, to moving the needle, to being transformative. We have to, but it has to feel comfortable, and it can be difficult. But you know, when you sit by and we'll talk about it on the last slide, but when you sit by and let it continue, are you compounding the problem? Is the checklist being implemented? Yes, Washington, D.C. Is using the checklist, they've implemented it. And again, it's really just sort of a mantra for the day, like a check-in, like I know that these are the things that I need to do, and they have them posted in areas where they can see it. We have not seen the follow-up feedback. The feedback that we've gotten is that they agreed that this was, the items on that list were feasible, were doable, for at least acknowledging that those are the areas where, they needed to focus on. And I think we talked about a lot of these. Don't stereotype, acknowledge and respect cultural and religious differences.
One of the big ones I really want to point out, we're coming near to the end of time, but is to find your tribe. Sometimes this work can feel like, you're really just, pushing against everybody else, and that it can feel, disheartening when you don't see any changes happening. So, align yourself, with people that feel the same, and that may not even be within your own environment, immediate environment, your work environment, but be around and connect with and get support. Roll things up other people, ask them, did I approach this right? Could I have said this differently? What could I have done? Or this is what I've done and I'm really shaking now. What can I do? What can I do? How am I doing this? Am I doing the right thing? And I think that is just going to help with motivating and supporting and encouraging. But because this work is hard, we've got to take care of ourselves. It's a battle, it's a fight. So we've got to make sure that we are supporting each other, we're supporting and taking care of ourselves, and find the people that we know are going to support us in the work that we're doing.
Next slide. I just wanted to give some time for talking. You can go to the next slide, Lauren. So we all want everyone here to be birth justice warriors. So we're probably a fair amount of midwives, so you already are. I think that we are, by nature of midwifery, are with women and always try to show up for them and speak up for them. And so we just want to, we want you to continue and want to hear from you. Is there, other things that you think that you can do? Someone recently, I'm working on my son's college essay. She gave this to me, sent this to me for a quote for him to use for his college essay. And she's about being silent, and is being silent complicit. And this is a quote from, he's a Holocaust survivor, Elie Wiesel, and he said, we must always take a stand, take sides, right? Neutrality helps the oppressor, right? Never the victim. Silence encourages the tormentor, never the tormented. So we can, our silence, not calling out, not speaking up, are we complicit in allowing it to continue? So that was really powerful to me, in that, as scary as it can be sometimes, maybe building my tribe and finding allies in this work, that I can, sort of begin to be transformative for change for women.
Remember who we're doing this for. It's to have better birth outcomes and to have better survivability and to reduce the disparate rates of maternal mortality and morbidity. One death is one too many. We are pretty much at the end now. We have some references for you and we will share these slides, but we do want to say thank you for this time, and we want to open it up to have some questions and be able to answer your questions.
I think there was one in the in here that I wanted to make sure I pulled out the checklist. Julia, did you want to ask your question?
Or can you hear me okay?
Yeah.
Yeah.
Sorry, I had dental work, so my face is not great right now. But I was just curious sort of what strategies, if anyone on the call is doing anything right now that seems to be working really well. I'd love to know what we can learn from you.
When you say working really well, you mean as far as advancing the conversation around race, improving outcomes? What specifically do you mean?
Really, any strategies that are focused on reducing the health disparity between white birthing people and Black birthing people. I know that it's something, in Pennsylvania, we are, trying to figure out how to incorporate more health equity work into our statewide PQC.
Yep, that's what we're doing. Yep.
Yeah. And so that was very interesting to me. I was kind of curious, maybe specifically around that, like, how did you get that up and running? It seems like with our state PQC, like there's interest, but there are lots of other issues that have taken priority, whether that's right or wrong. That I think that's the mantra, like, oh, we'll get to it someday. But I think we need to get to it now.
Well, I received some bias being the health equity chair. As the Brown health equity chair, I was moved. They decided they didn't need to have a separate subcommittee that consisted mostly of Black women from partner organizations, and took it internally. And which was interesting. I said, wait a minute, I'm working on health equity and I'm have some, disparity going on. It doesn't feel like it's equal. It was really interesting. But what we did, they brought it internally into our health, into the Georgia Department of Public Health. And what they really still continued and utilized the strategies that we recommended, which has been phenomenal. And they made it a part of their educational series in their bundles, in their QI work. And so it was really merely hiring the folks to do it's a webinar. It was web-based, right? Because we can't be in person. Making the investment that it's important, right? So it's always funding, making the investment. And so they offered a webinar for 75, Lauren?
Yeah.
70 of the hospitals, over 75 people to participate who are engaged. The March of Dimes has a they have a online, which I previewed recently, which is excellent. I think that they have to make the commitment. They have to want to do it. That is, to me, the easiest. And again, that's just information. That's just like the step one. Like, what are you going to do now? Like, what is going to be your commitment to this work? And it's not going to be one training.
Yeah, and work with a couple of hospitals that are actually were doing some really great work, and one in particular, as Kaprice mentioned earlier, some of with the Perinatal Quality Collaborative, the data was stratified by race, ethnicity, and so the perinatal quality specialist at this one particular hospital tried to start talking about implicit bias and start talking about, looking at race and racial disparities. And she was on a staff meeting once, and I think someone was unmuted and made an expletive about what she was doing. And so that was obvious that they weren't happy, but how she was able to kind of overcome that was by, she posted the data, race, ethnicity, and then she started to make it more interactive as a quiz. And she put a quiz up and she questioned like, which race do you think has the most hemorrhages? And, I'm not sure whether she incentivized it, but people started, responding, and then she gave them the answer. And again, it was, which race do you think has more seizures, or which race has this, and so she was able to infuse it in a different way so that it didn't kind of create the hostility that she got in the beginning. And also some of the feedback that she received was, the nurses would actually come to her and say, hey, I had this race patient come in, so I prepared myself, made sure that I really dug down and did the risk assessment. I made sure I had the equipment nearby. I made sure that, I started 2 IVs. So it was starting to, when we talked about the change in protocol and the change in mindset, you could see how this was actually changing mindsets in terms of how they responded. And they were really quite, so delighted to be able to go to her and say, when you put that up, it really made me think, and now I see how it's impacted my practice. Another facility, they did something similar, but they started to do rounds on the patients, and also started to document the race and the feedback. And so at the OB meeting, this was for physicians, at the OB meeting, the nurse director shared it with everybody. So up on the screen, they could see the responses, and they could see the responses from patients of all races for all of the physicians that were in that meeting, and whether the negative responses there were more negative responses from people of color. And so that was there for everyone to see. And you know, physicians don't like to be called out like that. They like to be on top if they're doing well. They don't like to be on top if they're not doing well. So that had an impact. So so I hope that's helpful. And Linda, I believe you have a question that you wanted to share.
Hi everybody. So hi Kaprice, I would love to connect with you. So I'm the co-chair of the New Jersey PQC's Health Disparities Work Group. So I think those of us who are working in this space, if we could network with each other and
awesome.
like lift each other up, that would really be so awesome, because like I hear you when we introduced this. So I got on the PQC as at that time I was president of the ACNM affiliate, and so I got on the PQC steering committee in that way, and then I negotiated this other position, and like when we first brought it up to the steering committee, there was like crickets in the room. And then I was still the only, and I'm old, I'm like really so tired of being the only person of color in the room. And I thought by now it would, be better. But anyway, so we got this committee established, this work group established. They keep kind of pushing back and we won't let them. So it's still going. We were able to get a seed money grant for a pilot project, because what we had heard from a lot of people is when they're doing the implicit bias training is, oh, I don't need this, folks, the pushback from people because they don't think they need the training. And what we said is, well, if you look at the stages of change, when you start at training, you haven't done you're still, and people are still in pre-contemplation phase. They're not ready to hear the training, right? You need to do something for preparation, for contemplation and preparation before you get to the training. And so we propose that having folks do the IAT, which I'm sure most of you are familiar with.
We did that
first, right, was an important step. And we were able to get some seed money so that we can go into 6 hospitals. So even though New Jersey is a small state, New Jersey thinks it's a big state. And so there's North, Central, and South. And so we've got 2 hospitals from each section doing the IAT as a beginning before they get into the training piece, kind of setting the stage for people saying. And the good thing about getting this seed money to do it, we have a contract with the IAT people. I can't remember the name of it. You know who I mean, Harvard. Yeah. So we get the data, and we've put, I put some identifiers in, not too many, because we don't want the CEOs of the organization to be able to identify who that one person is. But we have, what department they're in, what profession they are. And so the CEO gets, we don't share like one hospital's data with another. You get your data, and then you can see it before you even go into the training. There's evidence right there in front of you in black and white that there is this kind of bias in your folks that you're, in your staff. So it gives the CEO of the organization, who we've kind of sold on it already, the more a greater ability to then sell it to the rest.
They want the data. They all want the data.
Everybody loves data, that. So yeah, but I think it would be great for those of us working in this space within PQCs. They don't kind of share that information with us, but if we can reach out to each other and see what we're doing and support each other, that would be fantastic.
Yeah, so if you, Kristen, Kristen will give us the thing. If you're interested in that, just put your information in the chat.
I did already.
Yeah, that'll be great. And she'll give us the transcript. Yeah, it's a heavy lift of work.
It is, yeah.
It's a heavy lift. To have anybody else, any comments, strategies that's worked? We got 5 minutes.
Janet, you mentioned nobody knows what to do with it. Is that with the data or with the IAT results, or?
Thanks, Linda.
Usually they look at it and go, okay.
Oh, sorry, Jen.
Janet, we're having connection issues, I think, with you. Sorry. I don't know if you want to try to type.
Oh, no one knows what to do with the data?
Maybe the data. I mean, I must admit also with the IAT, it's not a one and done. You can't just do the IAT and expect to, okay, I have no bias, or oh, I have bias towards people of my race. It's not enough. We all need to dig a little bit deeper.
I mean, I think that, you know, we talk about this all the time about the training, and I'm like, I'm over the training. I'm like, okay, like what's the next step? But you only could get people to do things who are motivated to achieve change. And sometimes depending on who you're talking to, you have to show them, you have to use some data. And sometimes that is people's, either by bringing in personal accounts of things that have happened, looking at outcomes stratified by race, by, you know, and where your particular outcomes are highlighted. So sometimes you just have to figure out what's going to speak to that person, and being able to sort of even open up their mind to hear. Now, some people are closed, so you just move past them to the next person. And sometimes people just want to copycat, right? Once they see everybody's doing it and everybody's on board and what they're learning and what they're doing, sometimes people want to join in and be a part of it as well. So it's, you know, sometimes you just learn by just osmosis of them being in that place and everybody working together. It's hard though. We have some of those too. There's no bias.
Yeah. Well, we are getting some people in the chat, so I want to make sure everyone knows about the, you know, what people are sort of asking for. If folks are, you know, working with your perinatal quality collaboratives, where you are regionally or locally, and if you'd like to try to connect, I can help facilitate.
Yeah.
So,
and
yeah.
Also in communities, if you're working in communities, we're getting ready to start a postpartum initiative. We've been working with IHI and community organizations, and how, because, you know, most of the deaths are happening when they leave the hospital. I mean, really. So what systems, like who are we inviting to the table? Like, you know, the wealth income gap here is horrendous. The insurance, you know, who's insured?